Welcome everybody to the presentation of the special circumstances part in the ERC 2021 guidelines. My name is Carsten Lott. I'm the co-chair education of the Science and Education Committee Advanced Life Support within the ERC. It was my pleasure to organize and to coordinate the writing group for that guideline chapter. Without that expert writing group, it would never have been possible to get such an excellent chapter within our 2021 guidelines realized. We had some background information, some excellent systematic reviews done by ILCOR, but many of the parts that are covered in that chapter consist or are derived from individual scoping reviews and evidence update that have been done by the members of that writing groups. Getting into the conflict of interest, you may find that there are only few conflicts of interests, and they have been handled according to the route that we followed when producing the 2021 guidelines. Getting right into it, we have three major subsections. First subsection deals with special patient groups. This is not different to what we already described and published in 2015. This covers patients with asthma and chronic obstructive pulmonary disease, patients with neurological disease, obese patients, and the pregnant patients. There's not much changes, so it's mainly the style that has changed, the concise guidelines for clinical practice that are part of all our practice, of all our guideline chapters this times. But the content is mainly unchanged, clearly indicating that 2015 ERC already had excellent quality guidelines. The core or the heart of the special circumstances chapter is the special causes part. Special causes part describes the the reversible causes that are named the 4 H's and the 4 T's. And in all other parts of our chapter, we always refer to the reversible causes that need to be diagnosed, checked, and handled wherever possible. Hypoxia is the first one. Hypoxia, no changes to 2015. Provide the patient with oxygen in as much as possible to solve the underlying problems. Next is hypovolemia. Hypovolemia is split into 3 parts. We cover sepsis, we cover anaphylaxis, and we cover the traumatic cardiac arrest as well. And I will get you some more information on the traumatic cardiac arrest within the upcoming slide. Most important message for TCA is you should never pump an empty heart, and this might easily happen in a patient who suffered a traumatic cardiac arrest. If you have hemorrhage where the pelvis might be part of the reasons, then you should go for pelvic splinting for hemorrhage control. Resuscitative thoracotomy is another measure that should be undertaken if you have the expertise, if you have the equipment, and if the setting allows you to do so in your traumatic cardiac arrest patients. We added resuscitative endovascular balloon occlusion of the aorta, so the REBOA approach to our guidelines. And this is covered in the advanced life support chapter as well. Effective airway management and ventilation should be done as early as possible to prevent and to reverse hypoxic cardiac arrest in your TCA patients. Next one is hyperkalemia. Here we had the UK guidelines as an excellent basis for setting up that guideline chapter. You should consider hyperkalemia in cardiac arrest in all cardiac arrest patients. And as this is so, you should use point of care testing if that is available. If you find the patient in hyperkalemia, you should protect the heart using calcium chloride in a 10 milliliter, 10% solution. You should get the potassium back into the cells. You can use insulin glucose or sodium bicarbonate for that. You should try to remove the potassium from the body. You can consider dialysis in these patients. And this is what we state several times in the special circumstances chapter. You should consider, wherever available, eCPR in your patients and in prolonged cardiac arrest. If you haven't got eCPR available, you might go for mechanical CPR as well. The hypothermic part is slightly changed. This meets the prognostication part. So you shouldn't only go for the potassium, you should aim for going for the HOPE or the ICE score on your patients to get an idea if it is of prognostic value to transfer your patients to an ECMO, to an ECPR center. Your key interventions in this patient groups are insulation. You need to triage your patients. You need to transfer the ones that are eligible for treatment as fast as possible to an ECLS center to rewarm your patients. And you need to use a modified drug and shock strategy for your patients depending on the core temperature. So going for thrombosis, we cover the pulmonary embolism. If you have a patient with suspected pulmonary embolism, they are most likely in PEA once you find them. If you provide high quality chest compressions, you will end up with low EtCO2 readings anyway. So these are usually below 1.7 kilopascals. If available, you should go for emergency echocardiography in that patient group, and you should still administer thrombolytic drugs. And having done so, continue your CPR approach for at least 60 to 90 minutes in suspected cases. eCPR might be an option in that patient group as well. Coronary thrombosis. If you resuscitate your patient successfully, then you need to decide how to manage the post-resuscitation period. We split that approach between STEMI patients and non-STEMI patients. STEMI patients need to go for PCI as soon as possible. If you do not manage to do so, then thrombolysis might be an option if it takes you more than 2 hours to get them on the cath lab table. In non-STEMI patients, we recommend workup in the emergency department and then decision if you go for PCI or if you got other underlying reasons that need to be managed first in your coronary thrombosis patients. Cardiac tamponade is a very dramatic event in cardiac arrest patients. The only way to get behind that is to decompress the pericardium as soon as possible. Point of care echocardiography might support your diagnosis. And if you are able to do so, you should perform resuscitative thoracotomy in your patients, or you should go for an ultrasound-guided pericardiocentesis where you got the adequate equipment available. Tension pneumothorax, the next T. This is to be ruled out or found by clinical examination and point of care ultrasound. If you find tension pneumothorax as one of the reasons for your cardiac arrest, you need to go for immediate chest decompression. You can do so by open thoracostomy. This is the most practical approach. If you are not skilled to provide that thoracostomy, then needle chest compression might be an intermediate solution as well. Take in account that wherever available, you should use specific needles for that do not kink or that are not plugged very fast. You should prioritize chest decompression over chest compressions in patients suffering tension pneumothorax as reason for their cardiac arrest. Toxic agents, we provide the total news section on that. There will be an extensive supplement focusing on the single drugs that might cause cardiac arrest due to toxic agents. In general, if dealing with that underlying reversible cause, then you should ensure personal safety. You have available specific treatment measures, and these consist of antidotes. You should go for decontamination wherever possible, and if possible, then for enhanced elimination of these specific toxic agents. You need to take into account that there might be indirectly caused reversible causes as well, and this is electrolyte abnormalities or hypo and hyperthermia in your patients. You should be prepared for extended CPR measures, and here eCPR might be an option for management of your patients as well. If available, you should contact your regional or national poison center as soon as possible for advice. So this have been the reversible causes. We refer in all parts of our chapter to the reversible causes, and we have a third subsection. This is the special settings section. Here we cover healthcare facilities, we cover in-flight cardiac arrest, the HEMS cardiac arrest and cardiac arrest in air ambulances. We have a part about cruise ships. We cover sports, drowning, and mass casualties. Looking at the healthcare facilities, we recommend that you should take into account that you have additional resources available that you should use. And this is your staff, and you might have additional equipment that you can use to manage your patients. If surgery allows, you can consider open chest CPR on your patients, and eCPR is an option in these patient groups as well. So overall, to summarize our special circumstances chapter, if not stated different, you use the approach that is already recommended in advanced life support. If your patient has still a palpable pulse, use your ABCDE approach. Otherwise, follow the advanced life support, the ALS algorithm. If stated different, then you should try to prioritize your reversible causes and eventually modify the advanced life support algorithm. Many thanks.